strengthening the implementation of IPC programs as a core capacity of the international health regulations. The first session, which is today, we will be looking at an overview of the global IPC action plan and M&E framework. And we'll be starting with the housekeeping. Next slide. So WHO is committed to enabling events where everyone can participate in an inclusive, in a respectful, and in a safe environment. So colleagues, even as we discuss, as we ask questions, as we interact with each other, we're encouraged to do this respectfully with the highest ethical and professional standards. Next slide. We have interpretation available in English and in French. If you look at the bottom of your screen, you will see a globe icon, an icon of the globe. Written under it is interpretation. You can click on that and use the language that you are more comfortable with. And you can also mute original audio so that you don't have to hear what is being interpreted. We use the Q&A for questions regarding the topic and the presentations. Also at the bottom of your screen, you would see a box like a question with a question mark, and under it is written Q&A, and you click on that, you would be able to type your questions, and the panelists are there waiting to respond to your questions. There is another feature called the chat feature that is somewhat similar to the Q&A, but it is not the Q&A. For the chat feature, we're using that for general introductions, as we have been doing. Questions regarding IT, if you cannot hear properly, if your device is having an issue, that is where to put it in the chat. And there will also be somebody there to attend to those questions or your concerns. If you wish to take the floor, and here the panelists will be inviting you to take the floor to ask your questions live. You can also use the raise hand button. For some laptops, the raise hand button is standalone, it's just a hand like this. And when you click on that, we will know that you want to speak, and then we'll invite you to speak. For some other laptops, if you also look at the bottom of your screen, there's an icon called React. It's a love icon, and under that it is written React. You can click on that, and one of the options that you will get is raise hand. And when you raise your hand, we'll be able to give you access to speak. Next slide. Also, please note that by participating in this meeting as a participant and/or as a panelist, we're taking your attendance as permission to record your contributions and share these recordings via our various learning channels for continuous learning purposes. The session materials, including the session recordings and even the presentations, will be shared in the days following the webinar. Next slide. We collected a lot of data from you when you were registering. All of that data is confidential. It is kept with us at WHO. However, we may be using some of the data for reports, for maps, for communications, all of that. And just be reassured that the data will be de-identified before it is used for all of those things. Next slide. I will walk you through the agenda today. Welcome and housekeeping is by me. I have just completed. And then I will be handing over shortly to Dr. Miriam Nanuja for the opening remark. And after that, we are going to have the objectives of the meeting, several presentations on the state of IPC in the region, and an overview of the global IPC strategy and monitoring and evaluation framework. After that, we will get some country experiences from Togo and Malawi, and we will have a summary and expectations from our countries who have joined us today. And after that, we'll have closing remarks. It's a very short procession. So without further ado, I'm going to hand over to Dr. Miriam Nanyunja, who is the emergency preparedness lead here at the Nairobi Hub. Dr. Miriam, over to you.
Yeah, thank you, Amarachi. Good morning, good afternoon, ladies and gentlemen, wherever you are. I take this opportunity to welcome you to this webinar. I thank you all for coming, for such strong commitment, and to advancing the IPC in the African region. IPC is one of our core capacities under the international health regulations, and it is really essential for safeguarding health workers, patients, but also community members from the spread of epidemic-prone pathogens. It ensures that our health system really remains safe and resilient and does not become a source of amplification of the outbreaks. If we have this IPC in place at the lowest health facility, it can help to avoid the unnecessary spread of pathogens, but also the unnecessary exposure of our frontline health workers. Over the last decade, we have had several outbreaks, Ebola, Marburg, COVID, and we have seen how these have affected our frontline health workers due to a gap in IPC. And some of the key gaps we found was lack of IPC focal person, lack of the supplies that are needed and protective wear, lack of the guidelines, but also several countries didn't have any IPC programs. And all these together cause the systemic weaknesses in IPC that we are seeing in the different countries. And this becomes really dangerous because of the way it can lead to escalation of the outbreaks. We have seen in almost most of these viral hemorrhagic fever outbreaks, for example, that we get health workers affected in the initial part of the outbreak. We have seen this in the outbreak in Bulape. We have seen this in the outbreak in Rwanda, in Uganda, which is really sad. It means that we need IPC not only during the outbreak, but we need it routinely. In most cases, when there's outbreak, there's escalation of the IPC, and a lot of work is done during the IPC. But after the IPC, after the outbreak, all this goes down. What the IPC team is calling build and forget. You build during the emergency and then forget thereafter. We really would like to avoid this so that IPC becomes a way of practice in every part of our health systems so that it can prevent the unnecessary exposure. And one of the key things, I think, in this building of IPC is to have the IPC programs. We have the IPC guidelines and train all the health workers on these guidelines, but also have a surveillance system for monitoring these health facility acquired infections and getting a way to prevent them. And also the WASH, water, sanitation, hygiene, is also very important in the control of infections across our health system. I think that moving forward, this series is to guide us as countries, as officers in our different locations on how to strengthen IPC in our countries, starting with the routine and even being able to amplify the interventions when we identify these outbreaks. But we know that if we have the routine working well, it can prevent the unnecessary exposure to our health workers. So the team here is going to go through some of the key activities which are in line with the global IPC strategy that was approved in 2023 to 2023, and it is the global IPC strategy 2023 to 2030 approved by member states at the World Health Assembly. This guides us on what are the basics that we need to do, and the team will be taking us through this and also how we can apply them at our country level. I hope that at the end of this seminar and at the hope of the next seminar, we'll be able and have real practical solutions on how to improve and maintain IPC in our health facilities. I would like to really ask you to use this platform to learn from one another. We have these country experiences. We learn from one another, but also we recommit ourselves to sustained action. I know that together we can make IPC a core capacity within our health systems and ensure that we protect health workers, patients, and communities from unnecessary exposure. With that, I want to welcome you all and hand over the session to the presenters so that we focus more on the presentations. Thank you so much. Amarachi, over back to you.
Thank you, Dr. Miriam. Thank you for opening the session very nicely. I'll now be handing over to Tendai Makamure. Tendai Makamure, who is an IPC expert, also seated here with us at the Nairobi Hub. She will be going through the objective meeting and also the state of IPC in the region. Over to you, Tendai.
Thank you very much, Amarachi, and good morning, good afternoon, colleagues. And thank you, Dr. Miriam, for the great welcome remarks. And I think our title for this webinar is Build and Forget. Let us not build and forget what we would have achieved. So I'll quickly take you through the objectives for this session. So the overall objective as a core IHRA capacity through technical engagement, capacity building, and knowledge sharing. So through the specific objectives for this particular session, for today's session, is to review the status of infection prevention control in the regional, in the African region, to identify the progress we've made, the challenges, and what are the priorities areas for improvement. We also want to resensitize on the global IPC strategy, which was endorsed and passed in 2023, and our heads of states agreed to this strategy. So we want to set it as a reminder in this session to say we have targets that we have to meet by 2030, and hence we are going through it again to say let's have our eyes focused on the ball and maintain the momentum on strengthening IPC programs to ensure we reach the targets by 2030. And also want to ensure that we foster collaboration and learning through experience sharing from countries. We'll have best practices from Malawi, which has experienced a number of outbreaks and has significantly gone a long way in strengthening their IPC. Similarly, with Togo, you'll hear their experience on all the work that they have done to improve and strengthen their IPC program. So, ladies and gentlemen, these are the objectives for this session. And I'll now move on to my next presentation, which is giving the overview on the IPC status within the African region. Amarachi, can you confirm if you can see my screen?
Yes, we can. It's coming up. If you may please speak at a slower pace so that we can
Yes.
follow.
So this presentation sorry, can you hear me?
Yeah, we're having an issue with your internet. It's breaking sometimes. And if you can please speak
Hello?
at, can you hear us? Can you hear me? Tendai, can you hear?
Can I proceed? Yes, I can hear you. Can I proceed?
Please speak at a
Tendai,
slower.
we are requesting that you talk a little slower so that the
Okay.
interpreters can follow as well as the listeners. Thank you.
Okay. No, I couldn't hear you. Thank you. So I'm going to take you through the implementation within the African region, and this will provide the overview of the current status of implementation, drawing from national self-assessments, joint external evaluations that have been completed, state annual party reporting data, and also findings from the global IPC report, and also the global report on washing healthcare facilities. So just as a reminder, IPC is critical for patient safety and also for health security. I think during the COVID-19 pandemic, we experienced significant progress in establishing IPC programs, and we saw significant gains. But even with those gains, the African region remains below the global averages. So for the first one, I'll start with the data that came from the tracks, which are, and the tracks reporting. Tracks represents the tripartite antimicrobial resistance country self-assessment survey, and it is one of the key tools which is used to report on IPC implementation. And according to these tracks, for the 2024 report, the results show that 37% of the countries that completed, they still have no or have only partially implemented infection prevention control programs. We also noted that in this report, 15% have developed guidelines with nationwide implementation. However, we must note that from the report from the previous years, there has been a regression from 2023 when fewer countries were at lower levels, and this may suggest that investments and focus on IPC post the pandemic is slowly waning. Now we are moving on, building on. Now we look at the SPA data, the data that was from the state annual reporting data. We can see that most of the countries have demonstrated that they have IPC capacities at level 2 to 3, which is quite moderate, but is still limited in terms of where we should target to be. And also, again, we can see that throughout that on this diagram that is there on the IPC capacity, on all the components reported on IPC programs, on high surveillance, on the safe environment, we are still very much below the recommended average. And in addition to that, we can see that in 2023, from the data from the SPA from the 2021 to 2023, the IPC programs, there was a slight decline in 2023, and also the high surveillance and safe environment, they are at a low. I think the high surveillance is the one in blue. They are still at a low, although there was a steady increase from during the COVID-19, but there's not been significant progress since 22. It's more of a flat line indicating that there isn't much progress that is happening. And overall, I think we are still very much behind with regards to IPC capacities within the region and from the reports that have been shared. Now we move on to the data from the JE. On the JE website, after countries have conducted their JEEs. So from the countries that have completed and published their reports, the 30 countries, we can see that capacities are still those we've established healthcare-associated infection surveillance being the lowest performing indicator, where we have countries who do not have national high strategic plans and are also not implementing any form of healthcare-associated infection surveillance. Similarly, the scores on safe health environments, healthcare facilities is also quite low for the region, with the overall of 38.7%. So I think, as we can see from these findings, that although we are making progress, we can see that we still have significant gaps in components such as high surveillance, safe environment, and even on the IPC programs. So now going into each of these indicators on the IPC programs for the countries that are assessed, and we'll see that when we are doing the JE, it's out of 5. The scores are out of the level 5, 5 being the best, 0 being limited or no implementation at all. And from this assessment, we can see that 11 countries on IPC programs indicated limited or no capacity, which is the components on the red. And this one assesses the availability of a strategic plan, availability of a dedicated budget, availability of IPC focal persons at the national level, having the systems in place. So even though they indicated they are a level 1, doesn't mean there's nothing at all. It means it's still developing and it's still at a lower stage. 12 countries indicated some progress, but they are not fully functional programs, probably due to limited financing and issues to do with setting up programs for IPC. And on this one, 6 countries were a bit advanced, which recorded a level of 3 on IPC programs, indicating the dedicated IPC and possibly a dedicated program and also with some form of budget. And I think more than 3/4 of the countries still remain below the established capacity, with challenges in governance, financing, and national-wide program implementation, because the programs don't end at the national level, but down to the facility level, to the last level of care, which is the primary level. Onto the healthcare-associated surveillance, 21 out of the 30 countries indicated very low 1, meaning that they had no strategic plan for high surveillance. Some countries have been doing on sentinel sites, but we need now to use that data and also strengthen the lessons that we've learned and established from these sentinel sites to set up a proper healthcare associated surveillance and look at the priorities that we want to focus on. Only 8 countries had reached the level of 2, meaning that they had a strategic plan for healthcare-associated surveillance, and with only 1 country reaching the level 3. On the self-health environments of the 30 countries with reports currently published, 9 had level 1, and we are saying healthcare infrastructure, the layout, the setup, WASH infrastructure, very critical as key enabling factors for the implementation of IPC. And most countries are still indicating that they are quite low on that, on this indicator. And also 14 are at level 2, and with only 7 indicating a performance of 3. As you can see, this is less than half of the 30 countries. If 7 countries are at level 3 and 14 are at moderate, which is almost half, we are still lagging behind on all of these factors. Then on the report from the Global Health on the global strategy for IPC, the global report on infection prevention control, we can see that from the 37 countries, again, it's not all the 47 countries who completed or provided information, but we can see that we still have gaps in IPC program implementation, gaps in dedicated budget to support IPC programs from the national to the facility level, with 32.4% only saying they have. 64.9% have dedicated full-time IPC focal persons who have time dedicated to conducting the activities. But however, it still shows that from the 37, we still have countries that do not have full-time IPC focal persons at the national level to coordinate the implementation of the programs. 81% of the countries showed that they have updated national IPC guidelines, but we see a discrepancy here to say that, yes, they are developed, but there's a gap in the implementation at the facility level, as the score for adaptation and implementation declined to 78.4. Then we go to national IPC curriculum in service. Most countries are reported to not have, with only 48.6 having IPC curriculum for in-service training. Again, this all comes from having guidelines and using the guidelines to develop curriculum. And we are seeing that there's gaps in curriculum, and this will eventually translate to gaps in training as well. Then we have also, as we have already seen, challenges in high surveillance with 24.3%. and also IPC improvement interventions coordinated. 81% of the countries have made an effort to try and ensure that they at least appoint full-time dedicated IPC focal persons. The use of multimodal improvements strategies, the score was quite high, showing that in where they do the training and the guideline dissemination, they are advocating for this. And also plus national strategic plan for IPC, 48.6% of the countries, which is less than half of the countries, said they are monitoring their strategic plan. Another key indicator, which is hand hygiene, which is quite a key indicator, 64.9% of the countries have said that they have prioritized this as a national key indicator, which is again, not all the countries. So this is just going through the data that I was presenting on the previous slide, showing the gaps there. And I think some of the gaps, the strengths that we've seen were in guidelines and the use of the multimodal improvement strategies in healthcare facility. And we do acknowledge that at least 65% report hand hygiene as a compliance as a key national indicator, but we still need to have all countries doing this. And again, challenges in financing and dedicated budget, weak surveillance for health care associated infections, and also insufficient monitoring for infection prevention control implementation, both at the national and at the facility levels. And also now we are going to look at one of the three critical issues on WASH, which was published. And we can see that as a region, we are still lagging across the components. They look at the water, they look at the sanitation, they look at hygiene, they look at environmental cleaning and waste management in the healthcare facilities. And I think, as you can see on this graph on my right, we are still below average on most of the components. And I can say without water, safe water on the premises, we cannot properly implement IPC protocols. As you can see, water, safe water on healthcare facilities. This is washing healthcare facilities. We have around 63% of healthcare facilities across countries, all the countries, 63% having access to safe water. It is still below the average, the global average. And also, when we talk about sanitation, unsafe sanitation undermines IPC compliance and also can amplify disease transmission within the healthcare facilities. And we see this is where the largest gap, one of the largest gaps, we can see it on sanitation, where in the African region, in our healthcare facilities, we're still very much below the global average. As hygiene, on having hand hygiene in healthcare facilities, we can see that it indicates that there's been improvement within the region, but it's still below the global average, as we are having about 44% versus the 57%. On environmental cleaning, again, we are also lagging, and we are saying environmental cleaning is the backbone of IPC, and preventing surface and equipment contamination is quite critical, and we see we're not doing so well on that. Somehow we are doing well on waste management above the global average, and I hope the lessons from waste management, we can translate them to all these other components so we see improvements. So what are the key regional challenges in summary? We have seen that post-COVID, we have seen the decline in dedicated human and financial resources, and this is a big risk to sustainability. As we have already indicated, we must let go of the build and forget. We must continue reinforcing the foundations for IPC, strengthening the programs. We also have limited national legal frameworks in our countries for IPC institutionalization. We also have limited national and national budgets to support IPC implementation. We need the budgets at all the levels across the healthcare system so that we can adequately implement the IPC activities, the trainings, guideline adaptation, developing SOPs, continuous routine assessments, And also another challenge is the operational plans that have been developed are not fully implemented. And in some countries, they're outdated. And in some countries, they have not even yet been validated, which is one of the key challenges that we've been having. We have also been having challenges with the integration of the in-service curriculum for pre and in-service in most countries. So this could go a long way in strengthening IPC programs. And also weak national high surveillance system and also poor health facility infrastructure, as we have seen with the report on washing healthcare facilities. It needs to be a full package, IPC going together with WASH, because if we have gaps in WASH, it will simply be impossible to implement IPC. Some of the support that we have given to countries is in developing 5 year national strategic plans and annual operational plans, which are budgeted and with monitoring and evaluation frameworks. And we are continuing following up with countries on the implementation of the developed strategies to continue to identify gaps and also reprioritizing to ensure that we make progress, and also continuing to advocate for countries to validate their strategic plans. We have also developed a practical guide at the regional level for national IPC guidelines to help support countries to develop and update their national guidelines. The recommendation is to update the guidelines every 3 to 5 years. We also have the IPC in service curriculum framework, which has been piloted in 8 countries and is going to be validated, and we have started the dissemination. We have also been supporting countries during outbreaks to COVID-19, cholera, EVD, Marburg, with developing specific resources, SOPs, assessment tools, IEC materials, and all the resources that they require to respond to these outbreaks. And we continue advocating with countries that when they've conducted their STAR assessments and they've identified their high threat pathogens, they should also go down to develop their disease-specific IPC SOPs that are aimed at controlling the high-threat pathogens, if it's EVD, if it's Marburg, if it's Mpox. We have all the resources and we've been supporting countries to this. I think this is the end of my presentation. Thank you so much. Over to you.
Thank you so much, Tendai. That was very timely. We had gone over 3 minutes. Now I will be handing over to Dr. Landry Kabego. Dr. Landry, who is the Technical Officer for Infection Prevention Control at the WHO African region, and he is seated in the Dakar hub. Over to you, Dr. Landry.
Thank you so much, Amarachi. Can you hear me?
Loud and clear.
Thank you. Thanks to Ms. Tendai for setting the tone of this webinar. So my presentation will be focusing on 3 main objectives. And the first one will be to provide a comprehensive overview of the Global Action Plan and Monitoring and Evaluation Framework on Infection Prevention and Control. The second one, to outline effective implementation strategies of the main actions of the Global Action Plan. And then the last one is to briefly present potential impacts of infection prevention and control interventions on HAI, healthcare-associated infections, and AMR, antimicrobial resistance burden as well. For many countries, we have gone through this process when we are supporting the development of their national IPC action plan. More than 25 countries were supported. But for the countries that we have not supported, this presentation alone will not provide all the necessary information to go through the process. So if there is a country that needs further support to develop an app for IPC, we will have to schedule further consultation online for that. So Let's start with the first objective on the overview of the Global Action Plan. So in 2022, the first ever resolution on infection prevention and control was adopted at the 75th World Health Assembly, and it was requested to our General Director to develop a global strategy. And this was done and adopted to the following WHO in 2023. And in 2024, we developed the IPC action plan and monitoring framework. And every year we will have to be reporting back to the World Health Assembly the progress of the implementation of the Global Action Plan at country level, and also the impacts at healthcare facility level. So the global strategy has 8 strategic direction, and we'll go through these 8 strategic direction and provide some information on the key actions and the indicators. So from these 8 strategic directions, as I said, we have for each key actions that have been developed, and for each action we have a set of indicators that has been agreed on, and we also have a set core and additional targets outlined in this global action plan. And the purpose of this is really to help to meet the 2030 vision, which is everyone accessing or providing healthcare is safe from associated infections. So let's start with the first strategic direction, which is political commitments and policies. This is very important to have high-level commitments on the implementation of the IPC program at country level, because there is a need to have enough resources for that. The first action outlined is to develop a national action plan and monitoring framework for IPC, outlining costs and sources of financing. And then we have the second one, to establish the legal framework for IPC, which gives the mandates for the implementation of IPC at country level, and to develop the national financial investment case, to establish a dedicated IPC budget. As you know, implementing IPC without dedicated fund, it's quite impossible. And then the last action at national level is to demonstrate evidence of investments by national authorities in WASH and infrastructure services and staffing. At facility level as well is to demonstrate the commitment and support of healthcare facility senior managers to IPC through an adequate dedicated budget allocation to IPC programs and team. So in many countries, by experience that we have supported to develop the National Action Plan, we had countries where the action plan was approved, the budget was approved, but these were very few countries. We had other countries where the National Action Plan was approved, but the budget could not come with the action plan. And then we had some countries that developed the National Action Plan for IPC, which was not even approved. So there is a need to have this higher level advocacy, making sure that the IPC programs is getting enough support as needed. The second strategic direction is active IPC programs. And the actions, the first one at national level is to establish a national IPC program and demonstrates evidence of improvement of IPC programs, including WASH infrastructure. And then to support establishment of IPC programs, at least in tertiary and secondary facilities, and to identify IPC link person in each healthcare, primary healthcare facility. The other action is to establish national targets on reducing HAI. If, for example, for that we need to have a surveillance system in place to measure the burden of HAI, and according to the burden to set up the targets. For example, if the prevalence of SSI, surgical site infection, is, let's say, in the country 10%, you can set up a target for the next 1 or 2 years to reduce it up to, let's say, 2% or 3% using a set of interventions. And then we have another key action, which is to develop national IPC guidelines. At facility level as well, is to establish and activate IPC programs in tertiary and secondary healthcare facilities, as well as IPC link person at primary healthcare facility, and make sure that the fund is available for that purpose. The first strategic direction is integration and coordination, which cover inclusion of IPC principles, standard indicators within strategies and document of other complementary national programs like AMR, WASH, patient safety, TB, HIV programs, quality, etc. To ensure as well that IPC program is aligned with and contribute to other complementary national programs, strategies, and document, and to ensure that IPC clinical practical practices and appropriate prescribing of antimicrobial agents are embedded in policies related to patient care pathways at national, subnational, and healthcare facility levels. So let's go to the next strategic direction, which is around training and education. And this one covers mainly the developments and elaboration of a set of IPC curricula, which include the National Curriculum for IPC Professionals, a National Postgraduate IPC Certificates Program, a National IPC Curriculum for Pre-Graduates Training and Education, a National and Service Curriculum on IPC, but as well as to mandate that all health care workers, in particular those who are working in healthcare facilities, receive education upon employment. So we will, in the next couple of slides, we will show you as well what WHO is putting in place to support member states to implement these key actions. So the next strategic direction is the strategic direction on data for action, and this cover healthcare-associated infection surveillance, but as well as monitoring feedback of IPC practices. And what is recommended is to put in place national IPC monitoring systems, but as well as HAI and surveillance systems, but as well ensure that hand hygiene is prioritized as a key indicator at national level. And we have the strategic direction 6, which is on advocacy and communications. And let's go at facility level directly. And what is recommended is to organize events and communications and campaign on IPC priorities, topics like hand hygiene, AMR, and WASH, including patient and community participation. And then we have the Strategic Direction 7, which is on research and development. It's very important to have a country-specific national research agenda and priorities for IPC, adapted from the global research agenda, including a multi-sectoral and multidisciplinary approach. And the country should prioritize, fund, and implement research projects on IPC, because it's really important that the country understand the challenges and then adapt according to local priorities, local epidemiology as well. And then we have the last strategic direction, which is on collaboration and stakeholder support, mapping national partners, professional societies, civil societies organization, patient advocacy and community groups, and international organization relevant for IPC, and involve them into development and the implementation of the IPC programs. So for the coming slide, but before, I'm just going to let you know that the global strategy, the global action plan on IPC was developed based on the WHO core components for effective IPC programs, which has 8 core components covering IPC programs, guidelines, education and training, surveillance, monitoring, audit and feedback, workload, staffing and bed occupancy, as well as built environments, materials and equipment. So when it comes to the core targets at global level, we have 8 that retained our intention. And the first one, the idea is to have an increase of proportion of countries with a costed and approved national action plan and monitoring framework on IPC for more than 80% by 2030, an increase of proportion of country with legislations, regulation to address IPC, an increase of proportion of countries having and identify protected and dedicated budgets allocated to the national IPC program and action plan. As you know, this is one of the main challenge that we are facing in the African region, with most national action plan for IPC not funded, therefore difficult to implement. An increase of proportion of countries meeting all WHO IPC minimum requirements for IPC programs at national level, but as well as an increase of proportion in countries with national IPC programs at level 4 or 5 per SPAR 9.1 indicators, and level D and E in the tracks system. We have another target, which is increase of proportion of countries with basic wash in all healthcare facilities. And the other one is increase of proportion of countries that have achieved their national targets on reducing HAI, healthcare associated infections. And the last one, at global level, an increase of proportion of countries with a national HAI surveillance system. At country level as well, there are a set of targets, 4 targets that retain as well our attention. And the first one is increase of proportion of facilities meeting all WHO IPC minimum requirements for IPC programs, increase of proportion of facilities with dedicated and sufficient funding for WASH services and activities, increase of professional facilities, providing training to all frontline clinical and cleaning staff upon employment. And then the last one is around increasing the proportion of secondary and tertiary healthcare facilities having HAI and AMR surveillance system. So that said, let us go through some basic implementation strategies that we use to implement IPC programs and interventions at country level. WHO has developed this document which provide a practical stepwise approach to develop to the elaboration and the implementation of an infection prevention and control national action plan. And these documents really outline its tools, resources, country stories to help to prioritize, to cost, to implement, and to monitor and evaluate national action plan activities. And the primary audience for this document is the national IPC focal point, but as well as any person that has been designated as responsible for the development of the IPC map, but as well as for its implementation, as well as the multidisciplinary group around the responsible person. So what is recommended is to use what we call the five-step approach when we develop and implement the IPC National Action Plan. And the first step is preparing for actions, making sure that all the prerequisites for are in place, like the infrastructure, the leadership. A person has been appointed to be the one responsible for the elaboration of the NAP and its implementation, but as well as the multidisciplinary team is there, which include focal point from AMR, patient safety, and other related programs who can join the group to support the implementation. And the other prerequisite that need to be met is to start looking for fund for the developments, but as well as for the implementation. And after the step one, the baseline assessment need to be conducted, and usually we use the IPCAT 2 or the IPCAT minimum requirement at national level, and then the IPCAF and the IPCAF minimum requirements through at facility level for primary to tertiary. The third step is to develop and execute the plan. The developing now will take into account all the data that was gathered within the step 2 when the baseline assessment was conducted, and all the gaps identified should be converted into key actions, actions, and key actions, and as well as the indicators and the costs need to be mentioned for each action developed. And after the NAP has been developed, it needs now to be implemented. And throughout the implementation phase, there is a need for a continuous assessment of the program to measure impact before and after. And also for step 5 is to ensure sustainability of the program by putting in place long-term goals. So this is an example of that summarized the 5-step cycle for Senegal from 1 to 5. I'm not going to go through due to time. And also in the same document, there is advices on the implementation of all the strategic direction from 1 to 8, taking into account the 5-step approach of the implementation of the IPC National Action Plan. So in summary, when it comes to develop the NAP for IPC, we do the analysis, situational analysis using the IPCAT full or minimum requirements, the IPCAF, the wash fits, the hand hygiene. All these tools can be used, and then we conduct the SWOT as well. And then according to the gaps that have been developed, we are going to have some strategic objectives, and within each strategic objective we'll have priority strategic interventions, we'll have budgeted activities, we'll have sub-activities, and well as indicators, responsible people, and the deadlines. So let me go back a little bit on the 5-step cycle for Senegal, just to mention that Senegal mentioned that they've used for the baseline assessment the IPCAT minimum requirement, the IPCAF minimum requirements during the step 2. And that will be part of the topic that we will cover next week in the second session of this series. So this is an example of a template of an IPC National Action Plan and the operational plan as well. Just to say, when you develop all the actions, you need to prioritize which actions are you going to implement it within the first year, and these are going to be the object of the operational plan. So each year as well, WHO is publishing what we call the global report on IPC, and the latest one is the one in 2024. So you can look at these documents and find out what is going on in terms of the implementation of IPC in the countries for all the core components, for all the different targets that we have set. So the link is just below and you can get access to it, but it's published as well online in the WHO website. WHO has developed as well what you call the case for investment and action in infection prevention and control, which aim is to present the evidence for the expected return on investment in IPC. As you know, there is a huge burden of healthcare associated infections in terms of morbidity, mortality, in terms of HAI, in terms of economic costs due to prolonged stay in the healthcare facility. And this morbidity is much higher in low and middle income countries compared to high income countries. And implementing IPC can really prevent reduce the morbidity, but as well as help to save, to generate economic gains. So WHO has also developed this guide on the surveillance of healthcare-associated infections, which cover objectives, key concept, principle, methodologies, elements, and best practices on HAI surveillance to help establishing robust national and facility level HAI surveillance system. But as well as in these documents, we have the new WHO HAI case definitions for low resource settings. As you know, HAI definitions for many years has been very challenging because we are using HAI definition from high income countries, which included the need to have much more advanced lab infrastructure as well. But in the new one, they are a little bit alleged, and there are many criteria which are clinical, even though they still have some lab criteria as well. So at AT4 level as well, we have developed the practical guide for developments of consolidated national infection prevention control guidelines. And this has just been approved and should appear in the WHO Afro website in the next couple of days. Probably beginning of next week. And we developed this other document as well on infection, on IPC service curriculum. And this has been approved as well and will appear in the WHO website next week. So we will see and schedule maybe a session where we are going to go through these two documents. WHO Afro, we support as well the member states to monitor the implementation of the minimum requirements of IPC program at facility level in primary, secondary, and tertiary care using the IPCAF tool, the Infection Prevention Control Assessment Framework at facility level. And we support to put in place a digital platform to member states. We have some documents that are under development: the IPC pre-service curriculum, the practical guide on HI surveillance, the practical guidelines on implementation of IPC WASH standard in healthcare facilities, the preparedness framework for IPC for cholera, but as well as Ebola. So what could we gain in implementing IPC interventions in our member states? First of all, let me speak about this paper that was published in Lancet AMR series that indicating that reducing global AMR associated deaths by 10% by the year 2030 is really achievable with existing interventions, including IPC interventions. Secondly, we have 3.5 million deaths caused by HAI per year up to 2050. By implementing the multimodal IPC intervention at facility level, supported by national and subnational coordination, we could reduce HAI by 35 to 70%. But as well as we could reduce the burden of antimicrobial resistance by 85% with just IPC and antimicrobial stewardship combined. And around 600,000 AMR-associated deaths could be prevented annually in low and middle-income countries by improving IPC and WASH measures. In terms of economic return in IPC investment, IPC intervention have a very high return on investment. By investing $1 to improve hand hygiene, we have 24.6 in economic gain. This came from the way when we prevent HAI in the healthcare facilities, the patient will not stay longer in the healthcare facility. They will go back quickly to their home. The quantity of medicine that is going to be used will be less. The stay in the hospital is going to be less as well. And that will help to save a lot of money. And globally, implementing IPC intervention in healthcare facility using multimodal strategy and national coordination mechanisms could lead to saving of more than 100 billion USD in healthcare expenditure worldwide. So clearly we see the return on investment is there. And the case of investment document that was developed by WHO really outlined all these important elements that can help the national IPC focal points to conduct some advocacy activities at this level. Thank you, and over to you.
Thank you very much, Dr. Landry. And thank you for all of the documents that you presented to us and what our strategy is in the African region, and also what our target is. Colleagues, we have heard that we have targets to be met by 2030, and hopefully we will reach 80% of these countries with the IPC programs. So right now we're going to move to the next section, which will be the country experiences. I will be handing over to Professor Babaka Ndoye, who is an IPC expert, and he will be taking over the next session. Prof, please, we have only 10 minutes for the presentations and for the presentation for Togo, and another 10 minutes for the Q&A. Over to you, Prof.
Merci beaucoup, Amrachi. Je vais donc présider cette session pour 20 minutes. Et cette session sera ainsi composée. Il y aura une présentation de l'expérience du Togo par le médecin-colonel Kotoso, et ensuite une série de questions et réponses. I'm sorry for Anglophone because I'm more comfortable in French, so I'm going to speak French. Voilà. Donc, le médecin-colonel Kotoso est le point focal de la PCI au Togo. Il va vous présenter son expérience. Il est infectiologue, enseignant à la faculté de médecine de Lomé. Voilà, docteur Kotoso, si vous êtes prêt, on peut vous donner la parole. À vous.
Merci beaucoup. J'espère que tout le monde m'entend bien. Est-ce que vous me voyez? Je vais partager ma présentation. Comme on n'a pas assez de temps, on va aller rapidement à la présentation. Et je voudrais, pendant ce temps, dire merci à l'organisation qui nous a permis ce jour de partager l'expérience du Togo en matière de progrès de la prévention et contrôle de l'infection. Le professeur Ndoye m'a déjà présenté, il connaît très bien l'équipe du Togo pour avoir accompagné le Togo depuis le début du processus pour la mise en place du programme. Donc, au cours de cette présentation, je vais rapidement vous présenter un peu l'organisation sanitaire du Togo, mais le contexte de création du programme, de la prévention et contrôle de l'infection. Et puis, je vous présenterai quelques pratiques ou bien quelques réalisations que le programme a pu mener. Et je finirai par quelques défis avant de vous présenter les prochaines étapes. D'accord, pour résumer le système sanitaire du Togo, vous voyez, c'est un système pyramidal avec un niveau central, intermédiaire et opérationnel. Et au niveau central, c'est la structure du cabinet, mais aussi c'est là où se situe le programme. Vous allez voir tout à l'heure l'organigramme du programme. Mais nous avons aussi le niveau intermédiaire qui correspond à des directions régionales de santé. Dans certains pays, je crois que c'est appelé les départements. Ici, c'est la direction régionale de santé. Et au niveau opérationnel, c'est les districts ou des préfectures sanitaires, mais nous avons aussi des communes sanitaires au Togo. En s'agissant de soins de santé, même, nous avons aussi 3 niveaux de soins. Les soins primaires, où nous avons les agents de santé communautaire, mais les unités de soins périphériques, et l'hôpital de district qui constitue le premier niveau de référence des patients. Et nous avons 6 hôpitaux régionaux dans les régions sanitaires. Et au niveau tertiaire, nous avons 3 centres hospitaliers universitaires et 2 hôpitaux spécialisés, notamment le centre psychiatrique et le centre de réhabilitation. Alors, pour parler du contexte et de la justification de la mise en place du programme, je pense que les présentations depuis ce matin ont déjà abordé largement ce qui a amené d'abord l'OMS à recommander la création de programmes PCI durables. Et aussi, je m'en vais rappeler ici que c'est compte tenu des leçons tirées des différentes épidémies antérieures, que ce soit Ebola ou bien COVID-19, mais aussi de la recommandation de la 75e Assemblée mondiale de la santé qui recommandait la mise en œuvre des programmes PCI durables dans le pays pour éviter que les interventions de prévention ne soient limitées uniquement à la réponse aux épidémies et entre les épidémies, le personnel reprend ses habitudes de mauvaises pratiques. Donc au Togo, le contexte a été marqué par une priorisation ou l'inscription de la prévention et contrôle de l'infection comme une priorité dans le plan de développement, plan national de développement sanitaire, en son NAF 1 pour l'effet 10, et donc qui a conduit à l'élaboration d'un plan stratégique PCI durable. Et dans ce plan stratégique, il a été recommandé la mise en place d'un programme, la création d'un programme de prévention et contrôle de l'infection. Et donc, c'est ce qui a, avec l'appui du bureau de l'OMS, qui a conduit à la création de ce programme dont nous parlons aujourd'hui. Le processus de d'élaboration du plan stratégique était marqué d'abord par une analyse situationnelle avec l'outil EMAR à l'époque, et puis une analyse des forces, faiblesses, opportunités et menaces, et l'identification des interventions stratégiques, et finalement l'élaboration et la validation du plan stratégique. Dans ce plan stratégique qui était arrimé au standard minimum de l'OMS, nous avons ciblé au départ les 5 composantes, à savoir l'institutionnalisation du programme, les directives de la PCI, l'éducation et la formation en PCI, la surveillance des infections associées au sein aux services et la composante 5 sur le suivi, évaluation, audit et feedback. Alors, pour revenir sur la création même du programme, alors, il a d'abord fallu la mise en place d'une équipe technique au niveau national qui a procédé à une élaboration et une validation technique des tests de création du programme. Et ces tests ont été ensuite validés sur le plan administratif avec la signature de l'autorité ministérielle. Et ensuite, il y a la nomination du coordonnateur du programme avec une équipe centrale pour le niveau national. Et finalement, l'institutionnalisation du programme à tous les niveaux, au niveau des régions, et surtout au niveau des formations sanitaires. Donc, pour présenter l'organigramme du programme, nous avons au niveau central donc l'équipe de coordination avec ses unités et au niveau intermédiaire les comités régionaux de PCI et au niveau opérationnel, vous avez les comités préfectoraux qui correspondent aux districts, les comités communaux et puis les équipes PCI dans les formations sanitaires. Donc, l'équipe de coordination centrale, il faut dire que le programme est directement placé sous l'autorité du secrétaire général du ministère de la Santé. Et donc, l'équipe est composée, c'est une petite équipe d'un coordonnateur avec une unité administrative financière, mais une unité de planification, suivi et évaluation, une unité environnement bâti, une unité de communication et une unité de surveillance des infections associées au sein au service. Alors, je m'en vais vous présenter brièvement quelques réalisations. Il faut dire que le programme a été mis en place en avril 2023 et donc ça fait bientôt 2 ans et demi que le programme est en place. Et donc, depuis lors, il y a quelques réalisations qui ont été faites, notamment l'élaboration des directives des normes, la gestion intégrée des urgences sanitaires, l'amélioration continue de la qualité des soins dans le cadre de la PCI durable et la sécurité santé au travail des professionnels de santé. Alors ici, c'est le plan stratégique PCI durable qui a été élaboré bien avant la création du programme. Donc, juste pour vous présenter un aperçu, je ne vais pas aller dans les détails. En termes de documents aussi, ici, c'est le plan d'action opérationnel, donc qui dérive du plan stratégique qui est fait chaque année. Et donc, celui-ci, c'est celui de 2024-2025 qui est en cours d'exécution, qui va arriver bientôt à échéance. Ici, en termes de normes, c'est les directives et procédures opératoires normalisées en matière de prévention et contrôle de l'infection qui a été rédigée et diffusée à l'ensemble des acteurs à tous les niveaux, y compris dans les formations sanitaires. C'est la même chose pour les normes WASH dans les établissements de soins qui a été élaborée également et diffusée à l'ensemble des acteurs. Il y a également un guide de formation en prévention et contrôle de l'infection qui a été élaboré donc, pour pouvoir aider les formateurs à s'inspirer pour pouvoir faire l'encadrement continu. Alors, nous intervenons aussi dans les urgences sanitaires. Donc, ici, le programme a participé à la réponse à diverses épidémies. Je vous donne ici l'exemple de Mpox. Et alors, l'équipe de coordination centrale a été associée à l'équipe de gestion de l'incident pour le Mpox. Et au début, il a fallu faire une cartographie rapide, une évaluation rapide pour des capacités de réponse. Et dans ce sens, le programme a fait une cartographie des formations sanitaires en évaluant leur capacité à prendre en charge les cas de Mpox, notamment en matière de disponibilité des salles d'isolement. Donc, ça a été conduit sur l'ensemble du pays. De la même manière que le niveau central travaille, il y a aussi les équipes opérationnelles. Ici, je vous donne l'exemple d'une image d'intervention dans une formation sanitaire, donc d'un membre de l'équipe PCI donc, qui vient faire la désinfection après l'admission d'un cas dans une salle d'isolement pour le Mpox. Ici, nous allons au-delà des formations sanitaires, c'est dans la communauté. Alors, il y a des équipes d'intervention des districts dans lesquels sont intégrés les membres des comités de PCI, des districts, et donc ils vont intervenir sur le terrain. Ici, c'est dans une communauté, pour aller dans une maison où un cas de Mpox a été détecté en vue de faire la désinfection. Au-delà des urgences, nous faisons les activités pour la continuité du programme PCI durable. Ici, c'est une équipe de mentors qui arrive dans une formation sanitaire pour pouvoir installer les autoclaves qui ont été acquis avec le financement de l'OMS et qui ont été disposés dans la formation sanitaire, mais les praticiens n'avaient pas pu maîtriser l'utilisation de ces équipements. Donc, les équipes de mentors qui ont été déployées sur le terrain sont arrivées et travaillent directement avec les prestataires pour l'installation et la mise en marche de ces équipements. Toujours dans le cadre donc, de la PCI durable, nous avons des équipes qui vont sur le terrain pour faire le mentorat des activités. Ici, c'est la photo 1, le bio-nettoyage, donc avec un expert qui directement forme de façon pratique un agent chargé de nettoyage dans la formation sanitaire. Ici, par exemple, dans le cadre de la gestion des déchets, donc un expert, aussi un mentor qui arrive et qui travaille avec le chargé d'incinération dans une formation sanitaire. Ici, c'est un réanimateur, un médecin réanimateur, donc qui, après une évaluation dans les blocs chirurgicaux, parce que c'est là où les programmes ont difficilement l'accès, parce que souvent, c'est des environnements clos où le personnel spécialiste de l'hygiène et assainissement n'a pas souvent accès. Et donc, ce que nous avons fait, c'est de prendre des experts dans leur domaine, des spécialistes, ici, par exemple, un réanimateur, qui a eu des compétences supplémentaires en PCI et qui est chargé d'aller former et de rentrer dans les blocs et de faire appliquer les programmes PCI. Ici, il s'agissait justement de la surveillance des infections du site opératoire que le réanimateur est venu évaluer et il est en train de mettre en place un plan pour pouvoir, avec l'équipe, cette surveillance. Alors, ce que nous avons aussi comme réalisation qui est intéressant, c'est qu'au-delà de ce que le programme ou bien les membres des équipes font, les personnels d'information sanitaire ont une appropriation des activités de PCI. Et puis, c'est une équipe PCI d'une formation sanitaire qui est composée de médecins, d'infirmiers et de sages-femmes et d'instrumentistes. Donc, ils descendent dans la formation sanitaire, ils vont sur le terrain pour vérifier faire la revue de l'application des directives de PCI et de gestion des déchets, ainsi que de la pratique de l'hygiène des mains. Ça, c'est vraiment ce que nous avons obtenu, que nous pouvons dire avoir obtenu comme impact positif, parce qu'il faut que le personnel lui-même prenne conscience et s'approprie les directives. De la même manière, ici, on voit un gynécologue, c'est dans une maternité, donc un gynécologue champion en matière de PCI, a eu les capacités en prévention et contrôle de l'infection, parce que c'est difficile pour les équipes habituelles d'hygiène et assainissement d'aller dans les maternités, de rentrer dans les chambres d'accouchement. Le gynécologue qui a l'habitude de travailler avec ses équipes, ici est en train de faire la mise en pratique de l'hygiène des mains ou du port des gants, des équipements de protection, mais aussi à gauche, sur la photo 1, c'est l'hygiène autour des soins. Donc, ici, c'est un nouveau-né que vous voyez là. Et donc, la pratique de l'hygiène dans les activités quotidiennes autour des patients. Alors, pour dire que pour pouvoir faire ces réalisations, nous avons eu vraiment un appui des partenaires. Et en tête, c'est l'OMS qui a un appui technique et financier presque à toutes les activités du programme. Nous avons également le Fonds mondial qui nous accompagne, notamment l'apport financier et dans la formation, l'acquisition des équipements et du matériel. Nous avons l'UNICEF qui appuie le programme matériel et équipement, l'UNHCR aussi, le GIZ, l'OAS qui a participé activement à la formation, des experts en prévention et contrôle de l'infection, notamment les différents spécialistes, vraiment cliniciens ou le personnel de laboratoire, les chirurgiens, donc à qui nous voulons confier les tâches spécifiques pour des services dans lesquels l'entrée des équipes habituelles de prévention est difficile. Nous avons l'accompagnement du CDC Afrique également en ce qui concerne la gestion des urgences et le renforcement des capacités, surtout en matière de réponse aux urgences. Nous avons l'appui de USAID également. Alors, quelques exemples concrets, comme j'ai dit que l'OMS est le partenaire principal, et pour montrer en quoi l'OMS nous accompagne précisément, nous avons eu l'élaboration des documents de référence, que ce soit les directives que je vous ai présentées, les plans stratégiques, les normes, les curricula de formation en PCI, mais également l'acquisition de matériel et d'équipements en PCI, exemple de consommables de bio-nettoyage, mais aussi des autoclaves. Nous avons eu plus de 120 autoclaves qui ont été disséminés dans 102 formations sanitaires pour améliorer la stérilisation des équipements biomédicaux réutilisables. Il nous appuie également dans la formation continue et surtout à la mobilisation des autres partenaires. quelques bonnes pratiques pour dire qu'au-delà de tout ce qui a été dit, ce que nous pouvons retenir, c'est qu'il y a l'institutionnalisation du programme à tous les niveaux de la pyramide sanitaire, depuis le niveau central jusque dans les formations sanitaires. Et nous avons les normes et les directives, et le renforcement des capacités des prestataires, et nous avons entamé l'évaluation des systèmes de surveillance des infections du site opératoire pour commencer, avant d'entamer l'ensemble des infections associées au sein au service. Nous avons pu obtenir l'adhésion du personnel à la politique d'amélioration de la qualité des soins à travers les supervisions formatives et le mentorat, l'appropriation de ces stratégies d'intervention en matière de PCI par les praticiens hospitaliers. Alors, il y a quand même quelques défis. Ceci étant dit, il faut dire que la promotion des bonnes pratiques de PCI que nous présentons, c'est essentiellement dans les formations sanitaires publiques, et donc nous avons encore beaucoup de travail à faire pour faire mettre en jeu les formations sanitaires privées qui constituent une grande part du système de santé au Togo. Nous avons également des défis en matière de renforcement des capacités de mise en œuvre et suivi et évaluation des microplans dans les formations sanitaires, ceci pour permettre de générer les ressources, parce que lorsque les hôpitaux font leur microplan, il faut qu'ils prennent en compte des lignes sur la prévention et le contrôle de l'infection. Nous savons qu'ils ont beaucoup de priorités qui font qu'ils peuvent passer sous silence les activités de prévention. D'autres défis, c'est l'acquisition de matériel et d'équipements, notamment la mobilisation des ressources internes. Nous avons vu qu'il y a beaucoup de financements qui proviennent des partenaires. Et enfin, le développement du système robuste de surveillance des infections associées aux soins et aux services et de la résistance aux antimicrobiens. Que ce soit dans la création du programme ou dans les recommandations de l'OMS, c'est un
Vous pouvez
volet
finaliser
important
rapidement,
que nous n'avons
mon
pas
colonel,
encore.
finaliser rapidement.
Merci. Et donc, je vais finir par vous présenter donc ici le dernier défi, c'est l'impact éventuel d'un retrait de certains donateurs sur nos activités. Je voudrais finir par les prochaines étapes, c'est la continuité des activités, c'est surtout la mise en place du programme de surveillance des infections associées aux soins. Et terminer par ce proverbe comorien qui dit que clamer que le chemin est long, ne le raccourcis pas, c'est le raccourci, c'est faire un pas en avant. C'est ce que le Moupon dit du programme PCI au Togo. Merci beaucoup. Je vous remercie.
Merci beaucoup, mon colonel. Voilà, on doit d'abord vous féliciter pour les réalisations qui ont été faites depuis l'élaboration du plan d'action. C'est à signaler. Mais vous nous avez pris plus de 15 minutes, ce qui fait qu'il nous reste moins de 5 minutes pour finaliser. Donc, on prendra une ou deux questions au niveau de l'assistance pour essayer d'y répondre. Mais je voudrais juste faire un petit commentaire. Votre plan stratégique prend en compte les 5 composantes recommandées par l'OMS, mais ne prend pas tellement en compte la stratégie multimodale qui est une composante en part entière. En fait, au début, nous avons dit que c'est une composante qui est partout, qui est utilisée partout. Donc, c'est pourquoi on n'a pas pris. Mais en fait, le plan d'action qui vient d'être publié récemment en fait une priorité absolue pour l'efficacité du programme. Ce qui fait qu'il y a donc certainement, il y aura à faire un petit réaménagement dans votre plan stratégique très prochainement. Mais ça, nous aurons l'occasion d'en parler. Voilà, donc ceux qui veulent poser des questions, on va prendre une ou deux questions. Je ne vois pas de main levée. Ceux qui veulent poser des questions,
Il y a 2 mains levées, professeur, 3 même.
mais je ne les vois pas.
Bon, je peux les
Oui,
dire.
il
Il y
faut
a
donner alors.
Bruno et puis Valérie.
Bruno, allez-y, je ne vois aucune main. Bruno, allez-y. Est-ce que vous m'entendez, Bruno? Allez-y.
Bonjour à tous. Effectivement, je m'appelle Bruno. Et moi, je fais partie donc de l'équipe PCI du Togo, d'où venait le colonel qui vient de faire la présentation. En fait, c'était pas pour poser la question. Je croyais l'avoir désactivé. C'était juste pour applaudir. Et je n'ai pas su, puisque moi-même, je ne vois pas les mains levées ici. C'était juste pour l'applaudir. Excusez-moi. Excusez-moi, je fais partie de ce programme que je connais bien. Donc, il n'y a pas
Merci,
de...
Bruno. Merci,
Merci.
Bruno. Nous allons donner la parole à la seconde personne.
Merci beaucoup pour la présentation. Ma question, puisque et félicitations au Togo pour ce programme. Et je voulais poser une question puisqu'il y a sous-financement du programme PCI. Je voulais savoir quel est le budget annuel PCI au Togo. Merci.
Bon, on va demander à Kotoso de répondre à cette question. Allez-y, docteur Kotoso.
Merci beaucoup. Alors, c'est une des faiblesses, comme vous le constatez, mais le budget qui a été initialement injecté pour les actions de prévention et qui était disséminé entre 2 ou 3 services, parce qu'il y a pas que le programme qui faisait les actions du PCI, et s'élevait à hauteur de 30 millions de CFA. Alors, donc, nous sommes en train de nous battre pour que ce budget puisse être augmenté et que ça prenne en compte les autres aspects qui n'ont pas été pris en compte au départ.
Merci beaucoup. Je donne toujours cet exemple du Togo parce que le Togo, avant même la validation de son plan stratégique, le Togo avait, en matière de prévision, donné une certaine somme forfaitaire aux activités de la PCI. Ça, c'est un exemple vraiment à saluer et à signaler pour les autres pays. Je vois aussi quelqu'un qui demande la qualification du coordonnateur. Je pense que je l'ai présenté. Il est médecin, infectiologue et à l'université de Lomé. Voilà, je crois que nous sommes... Oui, Landry?
Vous allez prendre d'autres mains?
En fait, le temps qui nous a été imparti est terminé. Je ne sais pas s'il nous laisse encore avoir une ou deux questions ou pas. Amrachi, qu'est-ce que vous en pensez?
Apologies, Prof. We don't have the time to take 1 or 2 questions from this particular.
OK. Dans ce cas, nous allons...
Thank you so
Landry,
much.
vous avez une préoccupation particulière ou bien?
Non, je n'ai pas de préoccupation particulière, juste remercier Dr Kotosio pour la brillante présentation. Merci à vous.
Merci beaucoup. J'espère que j'aurai le temps aussi de commenter les présentations faites par Landry et par Tendai, parce que personnellement, j'ai beaucoup de choses à dire. Voilà, donc Tendai, je vous rends la parole pour la suite. Merci à tout le monde.
Thank you,
Thank you
Prof.
very much, Prof. Babaka. Amarachi, can you hear me? I think my network was bad before, so I moved locations. So now I'm going to move on to the next presentation, and I'm going to invite Dr. Owen Musopelo from Malawi, who is the Deputy Director in the Ministry of Health and also the IPC focal person. Dr. Owen, over to you.
Thank you so much, Tendai. I guess slides will be shared from that side.
Yes, they will be shared. And remember to keep to time, Dr. Owen. Thank you so much. Over to you.
Yes, I'll try to keep time. Welcome. Good morning, good afternoon, good evening. I'll present for the case of Malawi on infection prevention. Next slide. So our outline, we'll talk about the general information about Malawi quickly, and also IPC program, methods of developing IPC strategic document, some best practices, challenges, recommendation, and also some lesson learned. And next slide. So for those not familiar with Malawi, it's quite a small country, but with relatively high population, bordering Tanzania up eastern side. On the lower side, we're bordering Mozambique, and to the western side, we have our neighbor, Zambia. Our next slide. So IPC is well established in Malawi, and we have that organogram, the organization structure for Malawi. At the top there is the Ministry of Health, and IPC sits in the Directorate of Quality. IPC, as you remember, as you are aware, IPC is a quality initiative, so it sits under quality management department. We have a national focal person who is designated and also supported by the National Steering Committee that provides some advisory role. Below the national focal, we have satellite focals. These focal persons are closer to the districts and also closer to central hospitals. And we have structures in the district hospitals or district or secondary level facilities. And also in central hospitals, we have infection prevention focal person supported by IPC committee. And if you go to lower health facility level, like called health centers, in our case, we have health center focal person. If you're in a hospital, if you go to a ward level, we have departmental champions, IPC champions, and we have adopted that because we have noted that it's working to have champions at ward level. Next slide. So IPC program, it's enshrined in the Constitution of Malawi. There's a clause there to safeguard the health of all populations or all Malawians, meaning that infection control is very, very well recognized in the Constitution. And also, as I indicated, IPC committees are available in facilities and they report to quality improvement support teams. In the facilities, we have also a structure called quality improvement support team. And IPC is implemented through what we call the work improvement teams, the WITs, which are available in most of the facilities, including facilities providing maternal, newborn, and child health. Next slide. So, National Infection Prevention Control Focal Person coordinates with other related programs like the antimicrobial resistance programs. We have a program that is under Public Health Institute, and we work, we link closely. We have a technical working group that we IPC and those leading AMR are all represented. We also link with the WASH program because it's coordinated by another department. We link closely so that we all have a common ground preventing infection. So there's quite a strong link in that. In the public health emergencies, are you aware that when it comes to public health emergencies, IPC is a very key pillar, and we coordinate infection prevention during emergencies. And also, we have a program in country called Quality of Care program, and IPC is one of the service elements that is assessed in this program. Moving forward, IPC is also a key component in patient safety programs. And as a country, we're also trying to strengthen patient safety program. And IPC is already one of the key components in that. Next slide. So WHO has been helping us a lot in putting up IPC program in the country. And we have benefited a lot in terms of providing tools, up-to-date guidelines, policies, and even technical support, making sure that we build capacity, and also we are producing documents that are evidence-based. And I'm sure Tendai and the formerly Deborah Barasa came to Malawi to support us in the development of our national operational plan. They also support in coordination efforts between WASH sector and health program to increase the synergistic efforts. Next slide. So we have really focused on coming up with policies, guidelines to guide our IPC program. And in this regard, we'll start with the development of a national IPC policy, which the previous one was outdated. It dates back to 2014, and it expired in 2014, and there was a long gap before it was revised. So we thank WHO for their support and also continuously reminding us that the policies need to be up to date and they should be evidence-based. So in 2024, we reviewed the national IPC policy, and as I'm speaking now, we have an updated infection control IPC policy, which was endorsed by senior management. Next slide. Yeah, move next slide. So, but prior to that, we were also supported to come up with the national operational plan for IPC, and we have the operation plan, which is running from 2023 to 2030. And the processes of its development started with WHO supporting us to do capacity building in the process of developing it. And later on, we did situation analysis and evaluating the IPC situation. We used the tools, WHO tools, the minimum requirements, assessing IPC program. We also utilized the SWOT analysis and did a bit of desk review for the situation analysis. And then we had series of workshops to develop our draft. And then the draft was validated using key stakeholders in the Ministry of Health, in the public not-for-profit facilities, the academia, and also other stakeholders that work with us in IPC. And it was later endorsed through senior management. Next slide. And in all these documents, we made sure that the core components for strengthening IPC are taken on board. That's why you see that icon appearing, the core components for IPC. And currently, we are working at revising our the national IPC WASH guideline. It was developed in 2020, and it's now almost expiring because we set that after 5 years we need to be reviewing our documents, and we've been supported by World Bank and other partners to review this document. And we also shared with WHO Afro, which looked at the document and made their comments. And we incorporated some of the comments. We did the validation meeting, and now we are about to take the document to a technical working group. After that, we'll take it for endorsement to senior management. So the most important thing is that it has been a very consultative process coming up with this, involving all our partners, IPC focal persons in the districts and private, and also other stakeholders that are very key to IPC. Next slide. We are also working towards adapting the HISE surveillance handbook, and this one is the WHO practical handbook for HISE surveillance. We are supported by EXA. EXA is also supporting the region in adapting this HISE handbook, and we participated in the initial meetings, the regional meeting, and also we are supported in starting the process of now adapting it from the regional document. So as I'm speaking now, we are almost finalizing this document. We just need some little support so that we have a validation meeting, and then send it to technical working group and senior management for endorsement. But we are very excited because this is one area that the joint external assessment, we did not score well. We've scored very low, and we made a what? Yeah, I think this is one of the area that we wanted to focus on this year, to have a document in place to guide us in putting forward a system of high surveillance. I know the putting up a booklet alone is not the end of the business. We also need to look at the M&D tools, training package, so that we train selected healthy facilities to start reporting high. So it's an area that we're looking forward to support so that we achieve the goal. Next slide.
You need to start concluding, Dr. Owen. My apologies.
I'll conclude. So we had numerous partners that have been supporting us in coming up with the document: World Bank, Global Fund, WHO for technical support and even financial, UNICEF also. We also have another partner, Welcome Liverpool Trust, that is also supporting us. Next slide. So in terms of best practice, we've learned that good collaboration and engagement with key stakeholders is very key. We didn't have all the money, but with good collaboration, there's enhanced financial support, and we cherish the collaboration that we have, and also capacity building of healthcare workers. We have a team that we have capacitated, trained by ICANN, and they're very instrumental in helping us coming up with document. Next slide. So as I conclude, we still have challenges in the system. This system of monitoring highs, not yet established, but I think we have started the process. We still have challenges in having dedicated focal persons in the facilities, and this will keep on coming up and again, and also the budgets. And as you already highlighted in the previous presentation, WASH in most of our healthcare facilities is not very good. Next slide. So few recommendations to ourselves and our partners is that we need to make sure that we have established this system for monitoring highs, and this is at our heart. We need to advocate for designation of a dedicated IPC focal person in the facility. Otherwise, if people are working like part-time job, it doesn't work. We need to work on WASH, advocate for budgets in implementation of IPC, and also most importantly, we need to integrate IPC package in the pre-service so that when people are coming up into facilities, they're already aware, and also train more healthcare workers. Last slide. Last slide, please. My last slide is we have learned a lot in good coordination, very important, and also integration. We are going to speak the language of integration so that we leverage resources. And I think that's the last slide. Thank you so much for the kind attention. Last slide, please. Yes, that's the end of my presentation. Thank you so much, and thank you for allowing us to present at this platform. Thank you.
Thank you so much, Dr. Msopelo. And I think, colleagues, we can encourage and appreciate Dr. Msopelo and Malawi for the great presentation. I think for me, from the story of Malawi, I think it tells me that it is possible to institutionalize IPC. When I look back from where the program started and where you are right now, it shows that it is indeed possible to build these programs. And I like what you said, that even at facility levels, if IPC is treated as a part-time, it will not work. Congratulations on the outstanding presentation, and also demonstrating the structures on the first slide that you showed, that even to the department level, you have representation there. And I think it's one of the models of best practices that other countries can learn from. I'm now going to invite for questions from colleagues. We have heard from Malawi, from where they started from. And also another illustration was that when they do assessments, they indicated the gaps in the JEE, and they did not have a high strategy plan. And now, as we have seen from their presentation, they have developed, they're in the process of developing a strategic plan. So indeed, it is possible, colleagues, to institutionalize IPC. And also on the issue, colleagues, I'm talking, but I'm encouraging you to raise hands. I'm waiting for hands to come up, then I'll stop talking.
Can I comment a little bit before we get some questions?
Okay, yes, Landry, over to you.
Yeah, I'm just going to, I saw Dr. Owen said there is a big challenge with HAI monitoring. I think many countries are facing the same, but just to let you know that there is a WHO project on strengthening HAI surveillance around the world, and we have 6 pilot countries, including Oman, Pakistan, Iraq, Sri Lanka. But as well as from Afro region, we have Namibia that is within the project. And the idea at the end of the project, this country will develop the HAI plans and will implement. And there is a monitoring application app software that will be developed through this project. And I think this application, when it will be available, we can try to support the other countries to put it in place. So it's something that we hope that by next year we'll be able to support member states. Thank you. Over to you today.
Thank you very much, Dr. Landry. Colleagues, participants, I am inviting questions. You can raise your hand and you will be allowed to talk. But I'm going to briefly talk about some of the questions that were in the chat box. And also just to comment on the issue of funding, I think as we can see from Malawi, even with limited funding, they were able to pull together the different stakeholders who are in the countries to support programs. They talked about the operational plan supported by WHO, the updating of the guidelines supported by World Bank. They talked about the high plan supported by EXA as well. So I think in our respective countries, even as we continue to advocate for dedicated budgets at the national level and ownership within the governments, we need to map the stakeholders who are in our country and help guide them, aligning their priorities with our strategic plan so that they support its implementation. I see there is a question, there's a hand. Can you please allow Boinkoflo to, you can unmute Boinkoflo and talk. Boy, over to you.
Merci beaucoup,
Yes.
Dr. Tendai.
Hello.
Babaka, Boy, the country to talk. Hold on, please. Boy, over to you.
Okay.
Yes. Am I audible?
Yes, please go ahead.
Yes, thank you very much. Well, let me thank the Afro for having organized this kind of webinar. It's very much enlightening, and it's even reminding us of some things that we had maybe forgotten, or they slipped through the cracks. But mine is not a question. It's really a comment, and
maybe also a request for some level of advocacy, maybe beyond the countries. I think we all agree that as healthcare workers, that IPC is a cornerstone for controlling preventable infections. It's a tool to avert health-associated infections. It also optimizes the safety of care that we render to patients. And above all, it saves cost, healthcare costs, if done very well. But my impression, I don't know whether it happens across, but my personal impression is that it's like it's regarded as an intervention that is given. The intervention that is given where people perceive it as something that we have all learned, and therefore we need to discharge it or implement it. I'm saying that because what I see is that IPC as part of, I must say, health systems need also to be strengthened, even when there is no emergency. But what I see is that during the course of time, when there is no emergency, we are not really recognizing it. And when it comes now to emergency, that's when we really try to put effort. And I know that Tendai has talked about the fact that some strategies are implementable even without budget. I quite agree with that. But what I'm saying is that once it's not taken as a deliberate intervention, it will always lag behind, and we will always run when an emergency comes. It's part.
Okay, it seems we lost Boy, but colleagues, just to also mention that we have another session. This is a 2-series webinar, and I'm happy people are appreciating this webinar. Unfortunately, we have run out of time, and we have less than 3 minutes left, and we have to invite Dr. Miriam to quickly present on the key summary takeaways for this session. Dr. Miriam Sangamitra, can you please project? We will also share all the presentations, and we will continue engaging, and please let's join the next webinar session, which is in 2 weeks on the 20th. Over to you, Dr. Miriam.
Yeah, colleagues, thank you so much for the time. I think you have listened, and there's a lot that needs to be done on strengthening implementation of IPC as a core activity, as a core capacity of the IHR. You have also heard about the challenges, but still we, as countries and officers, we still need to take step by step, as we saw in Malawi and Togo, step by step to see how we progress. Next slide, please. So I think that there's progress being made slowly, but let's maintain the momentum and not build and forget, but continue to build. There are some key areas that we have noticed that remain weak and need strengthening. Each one of you has mentioned the HAI surveillance. I think we need to work on this HAI surveillance because it is the challenge that we face in these health facilities. This includes having the standard protocols, the reporting system. We have seen the focal persons At the health facilities, Malawi team has highlighted that. And also we need to have that continuous supervision at the health facility to ensure that these protocols and what are being implemented. The other thing I think also that we need to strengthen is training for health workers at all levels, especially the lower levels, starting with the lower levels, coming upwards to even the national hospitals. We know that outbreaks start at community level, and therefore it is important to ensure that we don't forget the primary levels when we are strengthening the capacity. But the other issue also beyond the training is availing the supplies that are needed, and this requires the budget. So we need to work on the budget, advocate for some budget to strengthen IPC. Then the monitoring and evaluation using the standardized indicators. There are many indicators, as has been highlighted by Dr. Landry, to track the IPC implementation progress. These are some of the things that we can start on right away, and ensuring that IPC is integrated within the broader health sector. Within the broader health sector plans and quality of care, to ensure that budget is available, but also to ensure their sustainability. I think these are areas that we can work on right away. Next. And so, next slide, please. And so the way forward I propose is that as countries and committees, groups, we adopt and institutionalize IPC. In the health sector, quality of care, we saw how it is institutionalized in Malawi, and it seems to take off well. Institutionalizing it, the IPC, the budget, underlining or updating the national IPC action plans within national context, but also align the national plans with this global IPC strategy 2023-2030, so that we all work towards the achievement of the goals. And then you implement and up to date your operational plans. Do not let them be expired like the one of 2024. Update and continue to implement, scaling up the IPC training, as I already said. Then disseminate the guidelines. We know that some countries have developed these guidelines and they're at national level. Please disseminate the guidelines. There are some few actions that you can take, but also monitor their implementations. We found some facilities where they have the guideline on the shelf and they're doing other things. So have the guidelines and monitor their implementation. Work on the process of establishing the national HAI surveillance from national level, going downwards up to the health facility level. And finally, the monitoring and evaluation systems for the IPC minimum requirements through the IPC program, through the quality of care, through all feasible means, but keep monitoring, identify gaps, and address the gaps. I think there's a lot that we still need to do, but we start from where we can, and we continue to strengthen, we continue to build on. IPC is really a core capacity that we need within our health systems. With that, I bring it to the close and maybe refer to Dr. who will give the closing remarks.
Thank you so much, Miriam. I hope I can be heard.
Yes.
Okay, thank you. Distinguished colleagues, partners, and participants, good afternoon, good morning, depending on where you are. With heartfelt
Thank you to everyone who joined us today from across the WHO African region and beyond. It has been a truly inspiring to witness your dedication and active participation in this vital discussion on strengthening IPC as a core capacity under the international health regulations. As we reflect on today's session, we are reminded once again why IPC stands as an indispensable pillar of global health security. Through the insightful overview of the Global IPC Strategy 2023-2030, we have gained practical tools for developing and implementing national action plans that can transform our health systems. The presentation on the state of IPC in our region painted a clear picture of both our progress and the challenges ahead, while the country experiences from Togo, presented by Dr. Kotoso, and Malawi by Dr. Owen Musopelo, demonstrated real-world adaptations that inspire hope and provide model for replication. The engaging Q&A sessions, along with Dr. Miriam Nanuja's summary of expectations from countries, have sparked meaningful dialogue and underscored the urgency of our collective effort. These discussions echo the harsh lessons from recent outbreaks that have exposed the vulnerabilities in our health systems. We've seen how inadequate measures turn health facilities into amplifiers of outbreaks. The loss of lives to preventable infections, including those driven by antimicrobial resistant pathogens, is a reminder that we cannot afford complacency. Yet, as we've heard today, progress is possible, from appointing IPC focal points and enhancing healthcare-associated infection surveillance to improving WASH infrastructure and training at the primary healthcare level, where risks are often greatest. The momentum built during the COVID-19 response, establishing national programs and coordination mechanisms, must not fade as emergencies subside. Instead, let us reject the build and forget cycle and commit to institutionalizing IPC as a daily standard of quality of care. Drawing from the reaffirmation of the 2023 World Health Assembly, we must harness innovation, including digital platforms for training, e-mentorship, and real-time monitoring to bridge gaps, even in resource-limited settings. By doing so, we protect our frontline heroes, safeguard vulnerable populations, and ensure no facility becomes the catalyst of the next outbreak. I extend my deepest gratitude to our moderators for guiding us with expertise and grace. To our opening speaker, Dr. Miriam Nanuja, for setting the tone, to all presenters for their profound contributions. As a special thanks to our participants for your thoughtful questions and unwavering commitment. As we conclude, let this not be an endpoint, but a catalyst for action. Carry this insight back to our teams, institutions, and countries. Translate strategies into sustained implementation, collaborate across borders, and innovate relentlessly. Together, we can embed IPC as the unbreakable foundation of resilient health systems, securing a safer future for Africa and the world. Thank you once again for your time, passion, and partnership. Stay safe, stay vigilant, and let us continue this journey united. This webinar is now adjourned. My name is Dr. Anderson Lat. I'm the team lead for emergency preparedness at the Dakar Emergency Hub for WHO. Thank you.
Thank you.
Thank you.
Thank you. Have a lovely day. Bye-bye.
Merci à tout le monde.
Do well to fill the post-session survey that we've put in the. Please support us with filling the post-session survey as we close the session. Thank you for joining us. Manjit, we can close now.